feel the skin. So I'm gonna say, I'm gonna put a little bit more lidocaine in here. You stick it in there, and you wanna go deeper to anesthetize the subcutaneous tissue, because you're gonna use that dilator. You might even bump it up against the clavicle and infuse a little lidocaine there to anesthetize the periosteum, as I mentioned. Okay? Once you've done that, get rid of it. Okay. So the different elements here, we've got the introducer needle. This is our J-wire. It comes prepackaged in this gizmo here. You can see the wire itself is right there. So the way you operate this, you put your finger on that little thing right there and use your thumb to move the J-wire in and out. I'm going to pull it back and pull the cap off. So now I've got, you see the wire coming out? It comes out as a J. So I think this is maybe what you were talking about earlier. Yeah. So it just preforms itself into a J. You retract it all the way back, and now you're ready to go there. This is the triple lumen catheter right here. You want to have these three ports charged with saline before you get underway here, okay? So, you know, there you go. All right. And finally, this is the dilator here that you're going to use, the dilator. There's a scalpel here that you'll also, it was a number 11 blade. It's that sharp pointed one. Okay. All right, so what we're going to do is we're going to take the introducer needle, which is a pretty big needle. It's like an 18-gauge needle. It's a pretty big needle. And we're going to come over here, get our landmarks. I've got my finger in the jugular notch. I've identified the middle and medial thirds of the clavicle. There's his head, by the way. Parallel to the floor, parallel to the skin. I'm going to slide it in, and as I'm sliding it in, I'm pulling back on the plunger. So I'm pulling back on the plunger like that. And when you're in subcutaneous tissue, there's going to be a vacuum. You're pulling back against resistance. So as you're pulling back, when you hit the vein, you'll get a flash of blood in here. There you know you're in. So once I'm in the vein, without moving the needle, and this is a big thing here, when you start doing venipuncture on each other, once you're in the vein, don't move the needle. Grab the needle with your non-dominant hand, like this, and remove the syringe, but now you've got the hole right there. Put your thumb over the hole, the opening, otherwise it's going to start sucking air in. Okay? Now you simply take your J-wire, like that, and this right here fits over the hub. And this thing comes off, by the way, like that. So you got to kind of watch out so you don't separate things. All right. I'm going to take this and stick over the hole, like, put it in the introducer. I need one more hand here. Put it in the introducer needle, and then I'm just going to use my thumb to start advancing the wire. And you see the wire comes out the introducer needle. And now you're going to put it in until you get to the mark. There's a mark on the wire right there. You see that dark spot? Okay, so we're going to get the wire in to our desired depth. That's 10 centimeters right there. So we're going to take, now that we're in properly, what we're going to do is we're going to pull it back till we see the wire, grab the wire, and just pull it off. Now, you've got the wire. What did I say about the wire? Never let go of the wire. So now you're inside. All we got to do is take the introducer needle and back it out like that. So we're inside the vein now. we take our dilator, well, excuse me, we take our scalpel, and where it's going into the skin, without cutting the wire, just stab the skin and make a little half a centimeter opening. Because this thing right here is pretty fat. That's why to try to poke this through somebody's skin is impossible to do. That's why you use that scalpel. All right, so you're just going to take this, thread it over the wire, like that, into the skin, and just rotate it until you get it all the way in, and that dilates the process. Okay? Then the dilator comes out. Now you've got the triple lumen. Again, without letting go of the wire. You take the middle catheter here, remove the cap, and then just thread it on in. Now see, I'm not letting go of the wire. You have to always consciously note that. When the wire comes out the end, then you can grab it from back here and start threading it in like that. Take it all the way down to the hub, okay? Now that the catheter is in, I can take the J-wire out. You're going to cover this port here because blood's going to start coming out. And you'll suture it into place. And that's all there is to it. It's just the order has to be that. So if we go ahead, are we ready? We are not even close to being ready. So are there any questions? And you can actually, not that you ever would, but you can actually re-thread this back into here so you can play with it. Okay?
How do you see the marking on the J-wire since it's in the needle and the needle's in the body?
No, you're looking for that right there.
Yeah, but isn't that in the body already?
As it comes out, as it passes by you. Oh, that's the marker right there.
Okay.
Yeah. Casey.
So your syringe, before you, like when you first stick, is it, because I know sometimes if you're just doing venipunctures, you can pull your syringe out and it'll fill before, like without having to draw back once you get your flash. Is that appropriate or inappropriate for this?
It will not fill automatically. You have to pull back on the plunger.
I mean, if you pull back before you stick,
You mean with the lidocaine or with the introducer needle?
with introducer needle, like if I was to pull my plunger back before
No,
I stick,
as you get it into the skin,
then
as you're advancing it, pull back. You always pull back on a plunger as you advance it, and as you advance the needle, and as you retract the needle. Okay? Now, this needle here, this needle only goes like that. It has a metal guide inside of it. It's not like a regular syringe. You can't pull the plunger all the way out. So it's very specific as to how it works. And you're not going to get a flash there. You want to pull back on that thing as you advance it. Okay? So over there in the lab, you're going to use the introducer needle. You won't use a dilator, but you use an introducer needle to hit the vein and then take it out and get your wire and your catheter going. In fact, it may be difficult to get the catheter through there, but you can certainly get the J-wire in the vein. Honey?
So then when you take the x-ray, you weren't sure that the
When you've sutured it in place, then you go get the x-ray. Now, it more than likely will be a portable x-ray that you'll do in the ER or ICU. Because you're not, you have to have a sick patient to be putting a central line in.
If you did go too far, like you're in the atrium or something, like the port on that looks like it has a place to suture, could you pull it out or would you have to start over?
No, you just cut the sutures that you put in and pull back and re-suture it in place.
Could
In
you
a
put
wet
the
spot.
sutures after?
Huh?
Could you-
No, don't wait, till after the suture. It's like endotracheal tubes. Always hold on to things or suture it in place because somebody's gonna jostle it and, somebody might, the x-ray tech, as she's trying to get this film behind or the reader behind the person could grab this thing and just pull it right out. So don't do that. Now to suture it in place, it has a couple of little things here. You see, this has wings on it that you can suture down. If you don't put it all the way into the hub, and you probably shouldn't, this little device here, you compress the wings and it opens up a channel. And then you put this over the thing like that.
And that's in the case.
And then there's another little
and
hard
introduce
plastic
it as a
thing
unit into
that
the
goes
vessel.
over top of this. And that's what you suture into place first, right there. And then you can come back if you want to and suture the back. You don't have to. The first one is good enough.
I appreciate
Brandon.
it. If you're flushing the 3 catheter ports with saline, is that like something that you do while it's all still sterile? Is that something that your partners do?
No, do this while it's still sterile.
Okay.
Take the cap off. Don't let it hit the floor. Put the saline in here until it drips. Put the cap back on, come to the next one, so that all 3 ports are full.
Is it a part of the kit then?
No, it's not part of the
Okay,
kit.
so it's just
You're
something-
gonna need to draw up some saline. Okay? Can we go?
Yeah.
All right. Yeah, so this is like a 10-minute video, it's real quick.
In the first 2 sections of this video, we will review the contents of a typical central line kit and the Seldinger technique. If you are familiar with these concepts, you may wish to skip ahead to the subsequent sections on anatomy and line insertion. Although the specific contents of a central line kit will vary by manufacturer, it will usually contain the following items: a chlorhexidine antiseptic applicator and a large sterile drape or half sheet for sterile preparation, 1% lidocaine and a 3 milliliter syringe with a 25 gauge 1-inch needle for local anesthesia, several 5 milliliter non-Luer lock syringes which are used for aspiration during the insertion, a variety of needles. These include a 22 gauge 1 1/2 inch needle that is used as a finder needle or for administration of a local anesthetic, and an 18 gauge 2 1/2 inch introducer needle that is used to cannulate the vein. A guide wire housed in a plastic assembly which is required for the Seldinger technique. Note that the guide wire has a spring-loaded mechanism that creates a 180-degree bend at the distal tip of the wire. The rounded leading edge of such J-wires allows the wire to bounce off the vessel walls, reducing the risk of vessel perforation. Note that the guide wire housing has a straightener sleeve that facilitates the insertion of the wire into the needle hub. An 11-blade scalpel, which is used to make a nick in the skin to allow passage of the catheter through the epidermis. A dilator, which is used to create a tract in the subcutaneous tissues for the catheter. A central venous catheter. Triple lumen catheters, as pictured here, are most frequently used. Size 7 French 16 centimeter catheters are typical, but other sizes are available. Triple lumen catheters offer 3 infusion channels that may be used to administer a variety of fluids or medications. Sheath introducers may be chosen instead of triple lumen catheters if a transvenous pacing or pulmonary artery catheter needs to be inserted. These devices are large. 8.5 French 10 centimeter is typical, and often include a sidearm infusion port in addition to the main lumen. Finally, your kit will also include suture material used to secure the device to the patient, and sterile gauze 4x4s that can be used to clean away excess blood from the field. This section will present a generic view of the Seldinger technique, which is used to place central venous catheters. If you are familiar with this technique, you may wish to skip ahead to the next section. Many important techniques and subtleties are not included in this section, which is intended only to demonstrate the use of the equipment. Be sure to watch the entire video for a complete demonstration of the procedure. Use the 3 milliliter syringe and the 25 gauge 1-inch needle to place a wheel of anesthetic in the skin. Switch to the 22 gauge 1 1/2 inch needle to place anesthetic into the deeper tissues. Next, attach a 5 milliliter syringe to the 18 gauge 2 1/2 inch introducer needle and advance toward the vessel. Pull back on the plunger as you proceed. Blood will fill the syringe when the vessel is entered. Carefully remove the syringe from the needle, insert the guide wire assembly into the hub, and advance the guide wire into the vessel. Once approximately 15 centimeters of wire have been advanced into the patient, remove the plastic housing, leaving the guide wire in place. You may now remove the needle so that just the guide wire remains in the vessel. Use the 11-blade scalpel to create a small nick in the skin around the guide wire to facilitate passage of the dilator and the catheter. Carefully advance the dilator over the wire and into the subcutaneous tissues with a slight rotating motion, and then remove it. Next, advance the triple lumen catheter over the wire and into the vessel. Finally, remove the guide wire from the catheter and place the end cap over the exposed port. If using a sheath introducer instead of a triple lumen catheter, the technique is slightly different. Fully insert the dilator into the introducer prior to the procedure. Once the guide wire has been placed, insert the dilator and the introducer as a unit into the vessel. Once fully inserted, the dilator and the wire may be removed together. The relevant surface anatomy for the subclavian vein includes the sternal notch, the clavicle, and the clavicular head of the sternocleidomastoid muscle. The subclavian vein lies posterior to the medial portion of the clavicle. Connective tissue fixes the vein between the first rib and the clavicle, giving it a relatively invariable anatomic position. Note that the subclavian arteries are located posterior to the veins and are separated from them by the anterior scalene muscles. Note also that the lung may extend to the level of the first rib. There are 2 approaches to subclavian vein cannulation. For the infraclavicular approach, which is the most commonly used, first establish the location of the clavicle. Place the index finger of your non-dominant hand in the sternal notch and your thumb on the mid-clavicle. Needle entry occurs 1 to 2 centimeters inferior to the junction of the proximal and middle thirds of the clavicle. The needle is held 5 to 10 degrees to the coronal plane of the body and is directed towards the sternal notch. For the supraclavicular approach, establish the location of the clavicle and of the sternal and clavicular insertion points of the sternocleidomastoid muscle. Needle entry occurs superior to the clavicle, 1 centimeter lateral to the clavicular head of the muscle. The needle is aimed 10 degrees anterior to the coronal plane of the body and is directed toward the contralateral nipple. Position the patient supine with the stretcher placed in 15 to 30 degrees of Trendelenburg. The bed should be at a sufficient height that you do not have to bend over or stretch during the procedure. Traditional practices of placing a towel roll between the scapulae and abducting the arm are not recommended. Open the central line kit on a bedside table positioned within easy reach. Before unpacking the kit, put on a face mask, surgical cap, and a sterile gown and gloves. Next, lay out the equipment on the sterile wrapping from the kit. It is helpful to arrange the contents on the table in the order that they will be used during the procedure. Test the guide wire to make sure that it feeds easily through the straightener sleeve and then retract it before proceeding. Pre-flush the ports of the triple lumen catheter with normal saline and leave the cap of the distal port removed so that the guide wire may be advanced through it. Cleanse the skin overlying the entry site with a chlorhexidine applicator, covering a wide region. Place the sterile fenestrated drape over the procedure area. Note that a large full-body drape should be utilized to reduce the incidence of iatrogenic infection. In this video, the infraclavicular approach is demonstrated. The technique for the supraclavicular approach is analogous, using the landmarks discussed in the anatomy section. Using the 3 milliliter syringe with the 25 gauge needle, place a wheel of local anesthetic at the needle entry site, which is 1 to 2 centimeters inferior to the junction of the proximal and middle thirds of the clavicle. Switch to the 22 gauge needle and anesthetize the subcutaneous tissues and the periosteum of the inferior border of the clavicle. Place the index finger of your non-dominant hand in the suprasternal notch and your thumb on the bend of the clavicle. Insert the 18 gauge introducer needle attached to a 5 milliliter syringe at a point 1 to 2 centimeters inferior to the junction of the proximal and middle thirds of the clavicle. The needle should be held at a 5 to 10 degree angle relative to the chest wall and advanced until it contacts the clavicle. Walk the needle down the bone and toward the subclavian vein. It may be helpful to push down on the needle with your non-dominant hand to guide it toward the posterior surface of the clavicle. Pull back on the plunger as you advance. Entry into the vessel will be heralded by return of free-flowing, dark venous blood into the syringe. If air is aspirated, the pleura has been violated, and the patient should be evaluated for pneumothorax. Any subsequent central access attempts should occur on the same side to avoid bilateral pneumothoraces. If no blood is encountered while inserting the introducer needle, slowly withdraw it while continuing to aspirate. If there is no blood return, withdraw the needle, aim more cephalad, and try again. Once the vessel has been entered, secure the hub of the needle with your non-dominant hand, taking care not to advance or withdraw the needle. Remove the syringe and immediately occlude the hub with your finger to prevent air embolism. Next, insert the tip of the guide wire straightener sleeve into the hub and begin to advance the wire into the vessel with the thumb of your dominant hand. In general, no more than 15 centimeters of wire should be inserted to avoid advancing the wire into the heart. Some guide wires have markings every 10 centimeters along the wire to assist with estimation of depth of insertion. If the guide wire does not pass with ease, stop and recheck for free return of blood from the needle with a syringe. If you are having trouble advancing the guide wire, withdraw it slightly, rotate it a bit, and try to re-advance. It is absolutely essential to never let go of the guide wire once it has been inserted, to prevent migration and loss of the wire into the central circulation. Once the wire has been advanced, first remove the guide wire housing and then the needle, leaving the guide wire in the vessel. Be careful to always maintain a firm grip on the wire. Next, use the 11-blade scalpel to enlarge the puncture site, making sure you do not cut the guide wire in the process. In this video, we demonstrate the insertion of a triple lumen catheter. If you are inserting a sheath introducer, follow the steps described in the Seldinger technique section. Hold the very tips of the dilator and the guide wire to steady them, and advance the dilator over the wire. Advance the dilator through the skin and into the vessel. Again, make sure that you always have a firm grip on the wire at all times. You may encounter some resistance during dilator advancement. A slight rotating motion may be helpful. You may now remove the dilator, leaving the guide wire in the vessel. Next, advance the triple lumen catheter over the guide wire. You must grasp the wire from the distal end hub before fully advancing the catheter into the vessel. Once the catheter has been placed, remove the guide wire and immediately cover the hub with your finger. Finally, place an end cap onto the open hub and flush all of the ports with saline. Secure the line in place with a stitch and place a sterile dressing over the line in accordance with local institutional policies. A chest radiograph should be obtained after all subclavian line insertions to assess for proper positioning of the catheter tip in the superior vena cava and to evaluate for iatrogenic pneumothorax.
Okay,